We are very glad to have the chance today to share this session with our friends and colleagues from Italy. This is a consequence of a meeting that we hold in Cosenza in Italy some months ago, where 4 different universities participate on a scientific meeting discussing the results of shock waves in different orthopedic pathologies. The the creator of all of this was Dr. Alfonso Di Giorno, who invited us to have this meeting between Italy and Latin America, and it was really a very unforgettable uh, meeting with the chance to not only to learn a lot from them, but also to make new friends and to make deeper the relation with many of our colleagues that we already knew. So, Alfonso, tante grazie. We are happy to have you now today
Good,
with us. Go ahead.
good evening.
Good evening, Alfonso. If you want to make the introduction, you are welcome.
Good evening from Italy. Good evening from Italy. I extend my personal greeting from my center and from Italy of Shockwave to the member of the International Federation Shockwave Treatment and to Daniel Moya for having wanted my center as founder and members, and again for having wanted to appoint me coordinator for Europe of the International Federation Shockwave Treatment, and also for having strongly wanted to organize this webinar. Welcome, Italy. Greeting from Italy to all participants in the international webinar with my friend Daniel Moya at the end of my Congress of the 25th of the March. We decided to bring to the attention of the international scientific world the use addressed at the data collected in my center by the 4 Italian orthopedic school, Unimore, Sapienza, Tor Vergata, and Magna Grecia, data relating to regenerative treatment with focal shock wave. A large part of the Italian University Orthopedic School was present at that Congress, together with the president and past president of Seaton and the Territorial Hospital Orthopedic. The prospective data of the multicenter retrospective study at 2, 6 months, and 1 year gave stable positive result in a variable percentage between 8 and 95% in the 4 pathology objected of the collection of the 4 universities in my center. I present to you the doctor in orthopedic training who collected the data for the 4 Italian orthopedic schools. Dr. Alessandro Donà and Dr. Matteo Cempini, orthopedic specialists of Unimore School. Dr. Matteo Cantore, orthopedic specialist of Sapienza Uniroma 1 schools. Dr. Salvatore Maria Tecce, orthopedic specialist for Tor Vergata Uniroma 2 school. The orthopedic school of Magna Grecia is not present today due to an internal event at the university today. Dr. Alessandro Donà of Unimore School will inform about the data collection of the shoulder pathology that collected by the orthopedic school, the University of Magna Grecia. A fraternal greeting to Leonardo Guglio, who is entrusted with the scientific management of this webinar. Thank you, Alfonso Di Giorno.
Thank you so much, Alfonso. We will go ahead with the scientific content, and Dr. Leonardo Guilov will be the first to talk about the indications of shock waves. We feel that we need to revise what we were saying for many years. We need to find a background related with evidence and Dr. Leonardo Gilov, who is former president of the Ibero-Latin American Shockwave Society and the Shockwave Society of Chile, will give us this introduction. Leonardo, thank you for joining us.
Thank you very much. You see my presentation?
Yes, we can see it.
Well, I am very proud to be with you today. Very proud to be part of the IFSWT new federation, and we has as a federation has born to make more support for the shockwaves in the world. So, and I'm very glad that too many people is hearing today to us with our new ideas as federation. And my first proposal is to have a new classification from ESWT for musculoskeletal indications this year, 2023. And I will explain why I think we have to have a new classification. This scene is very common that we can see in hospitals or clinics when a young doctor see in the upper part of these stairs a patient that is complaining about autolimited pathology as epicondylitis, for example, but it could be also a calcified tendinitis of the shoulder or carpal tunnel disease, that with the common measures that we take care in the first part of this, for the patient come for the first time, such as anti-inflammatory drugs, physiotherapy, or even injections in the zone of the pain. And even though the weeks has passed and this woman haven't have any good result. So what is the first idea of many doctors, young doctors? They think about the guidelines of the health authorities of the countries, and when some non-surgical treatment fails, the first thing that he's coming to his mind is, I am going to do surgery in this patient. But is this something that we don't have to analyze first? And I think that when we see this this sentence done by, or this aphorism done by this famous professor Robert Salter, that says that decisions are more important than incisions. I think that this is a very, very important thing that this guide has to think, and everybody of us has to think. When we have a failure in a very simple treatment, we have to think why that was that failure, and that failure could be with a bad diagnosis, some other pathologies that are influencing the bad result, and also when we have this idea, we have to go and see if the surgery is the first thing that we have to do. And for that, we have to think in the evidence-based medicine classification that you can see in all the meta-analyses that are done in different specialties. And these meta-analyses are divided in A, B, C, and I grades, being the A grade, the best level 1 studies that you can find in the literature. So when some pathology is having failure in the treatment, we have to go and see in the literature which good evidence level 1 studies are there. And let me tell you something that is surprising. Everybody of us have done in my specialty in different parts of our body, arthroscopic anterior cruciate ligament reconstruction, many the people that are doing knee, arthroscopic rotator cuff repair. Many of you are specialists in only in shoulder, carpal tunnel decompression, even total hip and total knee replacement. And when you go to the literature and see this meta-analysis done in 2021 by a very expert group of England and publishing that in this British medical journal, look, let us tell you what was the conclusions. Although they may be very effective overall or in certain subgroups, no strong, high-quality evidence base shows that many commonly performed elective orthopedic procedures are more effective than non-operative alternatives. Despite of lack strong evidence, some of these procedures are still recommended by national guidelines in certain situations. So when we are doing our common surgery, that is something that we are not going to get out. We never realized that there are some studies, meta-analysis that are telling us that yet we have to continue doing more good studies to prove something that for us is absolutely something that we have put in our profession daily. And the other thing that we never think about is, this is a very old paper that tell us that when you do a surgery, you are doing something that for the national services, the special and the insurance is much more expensive. And the trauma that we are doing is, even that we are improve a lot in this in the surgeries in the last years, is an aggression for the body, and it will be more slowly the recovery of these patients. So the question now is why we are not thinking in climb these steps, this staircase step by step. And if we see the first step that we must do is SVT, the first thing that we must think if we are going to go slower until the patient trying not to do aggressive things. And the problem is why we don't think about SVT until now. And I think that something has been interfering in this. When this technology appeared 25 or 30 years ago, the only thing the people, the doctors have at that time is that in vitro studies told us that some pathologies in orthopedic and in other specialists also were the support to indicate this treatment to the patients. And they decided by a consensus statement, and I think that is something that we have to think that has been a problem. And in a consensus statement done by experts, told us this will be the standardized approval indication from ISMST, chronic tendinopathies, improved bone healing, and also urology that was proved for a long time before. But in that time, this was something only proved by the experimental studies, no with patients. And we can understand that we can do this classification because we didn't have any other support than the studies, the experiments. But in 2018, Dr. Moya and also a group of us, including people that was the authors of the first consensus statement, did this revision, meta-analysis that was published in a very good magazine as a Journal of Bone Surgery, and told us that that indications, not all of them, was an indication absolutely proved. What happened? Only 2 of these indications was absolutely proved: calcified tendinitis of the shoulder with high energy and plantar fasciitis. But the other indications, even one indication that was very common in Europe, as in Austria, Los has Spanish people that don't do shock waves and first as and before surgery, even though that indication is partially proven, it's not completely proven. And there's some other indications that are not proven at all. For example, calcified tendinitis of the shoulder with low energy. And even though this this classification is still now being approved for all the scientific world, that but it's a consensus statement. Is not an evidence-based, non-biased consensus. So my proposal is we have to do it this in a different way. To make indications to shockwaves, we must have an three types of indication: evidence-based proven indications, partial evidence-based proven, and non-evidence. Getting profit of the paper that I have shown you, of the meta-analysis that I have shown you recently, that we can now know that we have evidence-based proven indications, we have partial proven indications, and non-proven indications. Why I think that this is better? This is better because it's a dynamic form of looking the indications. We can have non-proven evidence-based indication, but if we do level 1 studies and publish in the literature, we can have a climb of condition of the indication. So if we continue doing good studies, and as association, as a federation, we do protocols for the people do excellent studies, we can have more and more proven indication that will make this treatment something that have no discuss. Final summary. ISFT is a new federation whose creation aims to transform the study of shockwaves into something demonstrable in evidence-based medicine, avoiding any type of bias. The first indication when this technology has appeared more than 20 years ago for musculoskeletal pathologies were carried out by consensus of medical group, indicating which pathology seems to them would respond better because of the biological stimulation that SVT produced in vitro studies at that time. We didn't have experience in patients. This way of selecting indication is absolutely non-possible to continue in this 2023 because there is a great number of treatments done until now, some of which has been reported in the medical literature in a very low scientific quality papers. That is very important. No national health authority will accept consensus statements that are trying to be proved with a very low scientific quality papers. That is something that we have to improve today with our federation. Until today, we have only one meta-analysis. We did the consensus statement, but if Dr. Moya didn't do the idea to make that analysis, we didn't have nowadays an idea what was the result for what we are doing. Not other meta-analysis then can be found in the medical literature. And by my point of view, the review of the quality of all papers of this treatment that can appear from now on is the best way to have a clear classification of really proven indications, getting out one that are systematically impossible to demonstrate as in well-done research, like the calcified tendinitis treated with low energy. These arguments are why I propose this new classification for our new federation to modernize the good use of this technology that I'm completely convinced is one of the best things that in medicine has happened. Thank you very much, and excuse me the large talk.
Thank you, Leonardo. I would like to ask something to Dr. Gigliotti. We are very lucky that Dr. Gigliotti, who is a pioneer on shockwaves, has joined us. And Sergio, knowing all the development of the shock waves across the last 20 or 30 years, uh, what do you think about this? Because we face in many countries all over the world that the health agencies and that many health insurance companies do not uh, approved shockwaves practice. The last big problem was in Korea. And I think that in part is our responsibility to change that. Do you have the same situation in Italy? It is easier to get approved shockwave treatment? We cannot hear you. You should turn on the
Audio.
microphone.
Your microphone is shut.
Okay.
Okay. If there is much confusion in use of the shockwave in the world, because there is two technologies, focal and radial, and in the industry is is not have not as not a scientific approach in the different types of technology. So in Italy, for example, the public health in the public health only indication that is as a reimbursement only plantar fasciitis, specific tendinopathy of shoulder, and epicondylitis and non-unions. And the others pathologies have not a reimbursement in public health. And this is the reason of this is the FDA approval. So in USA only these types of pathologies have a reimbursement of private insurance, and so the same method in Italy is used the same method. So only 4 indication for the reimbursement of public health.
Good. So we need to work on more support, more scientific support for the other indications, or to demonstrate that it is not useful, but at least to have a definition. And the way is to work on good level of quality studies. Fortunately, we have the support of people younger than us, and Dr. Alessandro Donà will show their experience with calcifications of the rotator cuff. He will present their experience. He works with Dr. Giuseppe Porcellini, who is a well-known shoulder surgeon all over the world, and he will present a study that was done in the hospital of Modena, the university hospital. Go ahead, Alessandro. We can see your presentation. Perfect.
We don't hear.
Your microphone is turned off. You need to turn on your microphone.
Okay.
Now we can hear you.
Okay.
Good.
Thank you, Dr. Moi and Dr. Zono, for invitation. It's a pleasure and honor for me. And now I try to explain our little experience with calcific shoulder calcific tendinopathies and shockwave therapy. So, as you say, calcific tendinopathies have a different phase during their biological life, a formative phase, a resorption phase, and a tendon repair phase. And it's important to evaluate the size, the number, the position, and of course the phase, and possible associated condition like slap lesion, calf tear, biceps tendinopathy, instability, or arthrosis. And there are a lot of classification based on X-ray evaluation. Most used is the Bosworth classification regarding the size, and the Mole classification regarding the morphologic. It's very important the ultrasound evaluation to evaluate the position and the morphological features of calcification. As Professor Giuseppe Porcellini described in this paper, pay attention because in some cases there are a greater tuberosity osteolysis, and we prefer to perform a surgery treatment because the conservative showed poor outcomes. In general, regarding the treatment, literature says that conservative treatment show 90% of good outcomes. Which conservative treatments? A lot of options, for example, non-steroid drugs, steroid injection, the needling, and of course the shockwave. Regarding the surgical treatment, is the arthroscopic procedure, but is reserved only for chronic cases that not responded to the conservative treatment. Here we can see the needling procedure with ultrasound guided, and we perform this generally in acute phase and big calcification, more 10 millimeters. In these videos, okay, in these videos we can see the arthroscopic treatment in case of failure of conservative treatment and chronic patients. And we can see now in the video the deposits into supraspinatus tendon, and first we proceed to remove, and obviously after we repair the cuff. And regarding the shockwave therapy, the literature is agreed to say that is an effective option of treatment in reduction of pain and improvement of functional outcome. In our experience with Dr. Di Giorno, regarding 158 calcific tendinopathies of supraspinatus tendon with very, very good results. And so in 71 complete resorption, short and long term in pain control, and good functional outcomes. But in our study, we try to analyze the possible prognostic factor of poor or good outcome with shockwave therapy. And first, we divided into two groups according to the size. Group A, classification minor of 15 millimeters, and Group B, major of 50 millimeters. And after, all patients were examined by ultrasound, and we perform a subdivision into two subgroups based on the ultrasound form, arc-shaped or non-arc-shaped. Arc-shaped is a round and definite deposit with posterior cone of shadows. and 4 subgroups after this subdivision. A1, small calcification with non-arc-shaped. A2, small with arc-shaped form. B1, big calcification, non-arc-shaped, and B2, big calcification but arc-shaped form. Our treatment protocol included 6 sessions, 7 days the interval, no local anesthesia pre-treatment, 3,000 pulses with medium high energy flux density, frequency of 5 Hz, and ultrasound guided during the treatment. Clinical results was evaluated by VAS and constant score. And it's possible to observe that the group A1 in blue, remember, is the group with small calcification and non-arc-shaped form, show the best results in terms of pain and function. Opposite, the group B2 in violet color, remember, is the group with large deposit and arc-shaped ultrasound form, show the poor results in pain and in function. After we have performed a ultrasound follow-up at 6 months after the treatment, and we analyze the complete resorption in blue, the partial resorption in color red, and the non-resorption in color green. And it's possible to observe that group A show an 89% of complete resorption, and group B2 only 41%. Group B2 is large and arc-shaped calcification. Another interesting data is the higher rate of non-resorption in group A2 and group B2 with arc-shaped ultrasound form. In conclusion, calcification size is the main prognostic factor. The arc-shaped ultrasound form results in higher rate of non-resorption and unsatisfactory results if these 2 conditions are associated. And in this case, we prefer other type of treatment, for example, needling or arthroscopic procedure. Thank you. We wait on December to Castrocaro Terme for the battle. Thank you.
Thank you very much, Alessandro. Leonardo, do you have a question? Do you want to say something about this?
Well, I think that the way to select the calcification is, as Alessandro told us, the main thing to select the treatment we are to do. Even though one of the best indications in shockwaves is these calcifications, the selection of the patient is the main point that we have to take care of, because if we don't do that, any treatment will be a right treatment without having these parameters. So I think that what Alessandro has told us today is something that everybody of us has to do before doing a treatment. Thank you, Alessandro. Very good, your conference.
Thank you. Thank you.
Thank you. Now we will go ahead with Dr.
To select the treatment we are to do. Even though one of the best indications in shockwaves is these calcifications, the selection of the patient is the main point that we have to take care of, because if we don't do that, any treatment will be a right treatment without having these parameters. So I think that what Alessandro has told us today is something that everybody of us has to do before doing a treatment. Thank you, Alessandro. Very good, your conference.
Thank you. Thank you.
Thank you. Now we will go ahead with Dr. Matteo Cantore from la Università Sapienza from Rome, who will talk about epicondylopathies.
Okay. I'm not able to share my screen yet.
Yes.
Someone has to close the other one.
Do not worry, yes.
So I can't share my screen because someone else has to close.
Yes, Alessandro needs to turn off his screen. Okay, now you can go ahead, Matteo.
Perfect. Okay. Good evening. First of all, I wanted to thank the International Federation of Shockwave Treatment, Professor Moya, Professor Gumina, and Dr. Di Giorno for letting me present our results on the treatment of medial and lateral epicondylitis with focused shockwaves. Okay, let's start with a short summary of what are the lateral and medial elbow tendinopathies. So as we all know, tennis elbow is a tendinopathy that involves, or most frequently, the extensor carpi radialis brevis. It's the most common cause of elbow symptoms, of elbow pain, and affects almost 3% of the adult population. And it's very common in tennis players, but also in heavy tools workers. And a study from our university demonstrated that, especially in butchers, it's very frequent. And men and women are usually equally affected, even if in our study, men are more affected than women. Medial elbow tendinopathy is also a tendinopathy that affects the round pronator and the flexor radialis carpi. It's 5 to 10 times less common than the lateral epicondylitis, and affects most commonly people between 30 and 40 years old. And it's the most common cause of medial elbow pain. As we all know, the tendinopathy can be divided in 4 grades that obviously progresses until the structural and mechanical failure of the tendon. And how can we treat these pathologies? Also, in the literature, we have many articles that face this argument. And as we can see, we have many conservative and non-operative treatments, including the extracorporeal shockwave therapy, or invasive treatments that are the last resort as needling. So let's go to the literature, and especially in comparison between shockwave therapy and other non-invasive treatments. So in this study demonstrated that shockwaves are more effective than corticosteroids injection at 12 weeks. And in this other study that compares shockwave therapy to ultrasonic therapy, we can see that there's no significant difference actually in the elbow function, but the shockwave therapy showed a vast scale and grip strength better than the ultrasonic. Instead, always talking about shockwave versus another treatment, such as laser therapy, shockwave was always superior to this other treatment. So it looks like this is the way to go. So let's go to our study, what we've done. We've included all patients with acute or chronic pain, tenderness at the epicondyles, medial or lateral, positive to specific tests, absence of contraindications, and not responsive to previous rehabilitation treatments. The exclusion criteria are obviously inflammatory arthropathy, pregnancy, age under 18 years old, arthrosis, infections, neoplastic pathologies, but most importantly, are the coagulopathies, treatment with antiplatelet agents, or microinstabilities, loose bodies, the posterior nerve, interossal nerve, ulnar entrapment, or synovial or Panner's disease. All patients were asked to fill the DASH score and the manual elbow performance score were evaluated through the VAS scale and the range of motion, and specific clinical tests were carried out. All of this was done before the starting of the treatment at time 0 and 2, 6, and 12 months of follow-up. This is a brief summary of what are the Mayo Elbow score and DASH scores, both developed in the 90s. And in the Mayo Elbow, the higher score corresponds to better condition of the patient, and the opposite is for the DASH score, where a higher score corresponds to a worse condition. These are just 3 of the specific tests, the Cozen, Maudsley, and Mills. And this is the therapeutic protocol that we've done with the patients. Variable number of sessions, that was minimum of 5 once a week, and repeatable in the following months. 3,000 pulses per session at 5 Hertz for 10 minutes, and the energy level was variable and dependent on the patient's tolerance. And these are the results. We've treated 70 patients with a mean age of 50 years old, more males than females, and obviously the effective side was most frequently the right one. And an important thing to see is that to underline is that the level of sport activity. As you can see, the most frequently affected patients were the ones that define themselves at mid-level, and usually mid-level are middle-aged people, males or females that play paddle or soccer or something like that and get injured. Not soccer, sorry, tennis or golf, and get injured. Instead, the minority of patients was a high-level athlete. This is why, probably because they train better, they work out better, and they warm up better. And these are the results, graphical results of our VAS. As you can see, the pre-treatment value was of 6.7, and it decreased very much after the last session. So after 5 weeks, it dropped down to 2.9, and after 1 year, it was 0.9 is nothing. For the DASH score, you can see that always after the last session, very important decrease. It's from 26.3 to 12.9, going until 3.2 at 12 months. Same thing for the Mayo score. It almost touched 100 at 1 year. So it looks like focused shockwave therapy is the way to go with these pathologies. Thank you very much for your attention. This slide doesn't show it, but I wait you at the International Congress of Shoulder and Elbow Surgery in Rome. That's organized by my professor Stefano Gumina and Alex Castagna. Thank you.
Thank you very much, Matteo. For sure, we will be there. We are eager and expecting this Congress. Well, epicondylitis is one of the controversial indications. Those of us who have personal experience are really very happy about the use of shockwaves. But if we consider, for instance, a recommendation given by Cochrane, they said that they analyzed some years ago several papers, and the result was not good. After that paper by Buchbinder, there was another paper by Furia and other author from Italy, and they realized that many of the studies that were included in Cochrane collaboration paper were perhaps their statistics were perfect, but the medical criteria and the way they were applying the shockwaves was not correct. So that is one of the problems that we face. Some of the studies are performed by epidemiologists that have not clinical experience on the use not only of shockwaves, have no clinical experience at all. So I don't know if you have the same feeling. I understand that these kind of papers that you are presenting will help to give support to this indication.
Yes, I fully agree, because one of the important things, as in calcific tendonitis, is that the indication. As I said, differential diagnosis is the most important thing we have to do in these cases, because especially in the elbow, many surgeons are not so specialized. So maybe you don't recognize a macroinstability or a syndrome of the plica. So that's the important thing to do. And another thing is the capacity of who does the focus shockwave treatment. The important thing is how you do it, and Di Giorno is an expert in this, so the results speak for themselves, as you have seen in the presentation. But yes, I think that the two main columns of this presentation are the indication and the way you treat the patient. That's all.
Perfect. Thank you very much, Matteo.
Thank you.
I see that Giuseppe joined us. Giuseppe, can you turn on your...
Ciao, ciao
Ciao
Daniel.
Giuseppe, benvenuto Giuseppe. How are you?
Grazie, mi fa sempre piacere vederti. I'm very,
Well.
very and very interesting the pathology, because is not so simple, and probably in the shoulder, as you know, calcific tendinopathy is very common, but is not so easy to treat and to evaluate and to classify the calcific deposit.
Yes, completely agree. Thank you very much for being with us. I know that you are very busy and you are working and traveling a lot, so I really appreciate very much taking your time to be with us today.
I wait in Rome, of course, in September, Daniel.
We will meet there. I was telling our friends that I am very eager to be there.
Daniel,
Ciao, Daniel.
Ciao, Giuseppe. Grazie.
Ciao, ciao.
Ciao, ciao. Leonardo,
Daniel,
go ahead.
It's only something that I want to say. We have created a new federation. And in this federation, we need to oblige us to have protocols, to common protocols to do the new papers about shockwaves, because if we don't have protocols and everybody feels incapacity to do these papers without the protocols indicating that they are level 1 studies, this technology will never be standardized and accepted for the medical community. So I think that we have a large work to do, trying to make all the federated, the people that is federated to do these papers level 1 ever, and not more this type of papers that make the people have doubts what they are doing. So I think we have this federation has born with that idea. I don't know if you agree with me, Daniel, but I think that all of us has that idea in the future.
I completely agree, Leonardo. I think that if we put together all this energy and this way to see things, we will find support. And of course, no one of us want to make an indication of a procedure that is not useful. So if the data showed us that for some indications is not good enough, of course, I think that will change our practice for sure. We will move ahead. Now we have Dr. Matteo Stempini from Modena, who will talk about greater trochanter pain syndrome, another complicated
Everybody.
pathology.
Yeah, so just give me 1 second.
Yes.
Okay. Not that one. Okay, presentation from the beginning. Okay.
Okay.
So, hi everybody. I'm Dr.
Excuse me, Matteo, we cannot see your screen yet.
No, really?
No, not yet.
Okay, sorry.
Check it.
Okay.
Share screen, Matteo.
See.
Okay, now it's coming. It's yeah, perfect.
Is it going?
Now we
Is it
can see it.
working? Okay, perfect.
Thank you so much.
Okay, hi everybody. Thank you for Dr. Gumina, Dr. Moya, and Di Giorno for joining me. And I'm Dr. Matteo Cempini. I'm a resident student at the University of Modena Reggio Emilia. And the aim of our study is to see how useful are the focal shockwave in the graded trochanter pain syndrome. So in our study is composed by 61 people, 61 patients in a median age of 55 years old, a BMI that is 22 people with a BMI lesser than 25 and 39 people with a BMI over the 25 with different type of physical activity levels from sedentary, gentle, or moderate. So we didn't take in consider like the professional athletes, and our patient have done at least one of diagnostic investigation like X-ray, ultrasound, or MRI. And we discover in the 36%, so in 22 people, some type of different type of calcifications. Our criteria of inclusion were atraumatic pain and pain on palpation of the graded trochanter, absence of medium severe coxarthrosis, and negative LASEG sign. On the other hand, our criteria of exclusion were the specific contraindication of the focal shockwave therapy, severe coxarthrosis, and vertebral, hip, or pelvis fractures. Our protocol of treatment is based on 6 sections, 1 per week, with we use 3,000 of impulses per section with an energy of 0.2 millijoule, a frequency of 6 hertz. And it's important to underline how the pressure exerted with the manipulus angulation and the manipulus movement is completely operator dependent. So the operator must have a good knowledge also of the machine and also of the disease. And we didn't use any type of local anesthesia. Our evaluation scale that we have used were the visual analog scale, a scale of pain, so that goes from 0 to 10, 0 no pain, from 10 that is the worst pain I've had. Then we use the Rolls and Madley score, a score that is divided in 4 categories. The excellent, so the patient has no pain, full movement of hip, joint, and full activity. Good with occasional discomfort. Acceptable, some discomfort after, for example, long walking and so on. And poor, with where the pain is completely limiting the activity. And also we use the RECIP score, a score that takes in consider the pain, the activities of daily living, and the range of motion. As you can see, our results, here's the result of the median VAS score. And as you can see, before the focus shockwave, we have a median score of 6.5, and then the decreases, there's a very important decrease in the previous 2 months, and then tend to stabilize in the year. And we saw that this type of indications, this type of line is similar also in the other score, like the Harry-Sip score. Also over here, as you can see, before the focal shock wave, we have a median hair receipt score of 62.5 that in the first 2 months get better and better, and then in the year, so after 6 months and the 12 months, the line tend to stabilize. And also in the Rose and Medley score, we goes from 19 people that has a poor, they say the poor, so have the pain that is limiting the activity, that goes from 19 before the focal shock wave to 10 after 2 months. And then, as you can see, also in the 6 months and 12 months, this condition the pain stands to stabilize. Thank you for the attention. Okay.
Thank you very much, Matteo. Another very interesting case in which diagnosis is key, because we have a lot of symptoms that are overlapping from the low back pain, and sometimes both problems are presented together, and it is not easy to recognize the origin. Which are the considerations, the clinical considerations you put in practice to rule out those patients with low back pain or with a low back origin of the symptoms?
Well, in fact, one of our including criteria was to the lag-zag sign, because actually, as you said, the problem of the great retrocranial pain syndrome maybe sometimes is a multifactorial problem, that just there's no only the grand trochanteric pain syndrome, and maybe there are also other conditions. For us, the problem is also the very big problem of the focal shock waves is to understand the type of patient and the type of indication. And so in that case, was not so easy to divide this type of groups and understand if the pain is just only for the graded trochanter or go back from the back pain and so on. So one of these was the lag-zag sign for us, and also there should be not severe coxarthrosis, because also the pain of the greater trochanter could be also multifactorial. So it was not so easy to decide what type of people to get in our study. This is one of the problems, and this is the problem is when to take the good indication for the focal shock wave. Otherwise, if you have back pain for other back pain or coxarthrosis, the focal shock waves are completely useless. Okay.
Good. Perfect.
Daniel, I have a question.
Yes.
Question to the presenter. When you are talking about protocols, you have you don't have to forget that there are 3 types of production of shockwaves. When you are talking in your protocol, you are using electrohydraulic, electromagnetic, or a piezoelectric machine, and this machine was with one glass or with multiple glasses, as now the industry shown us. I think that is very important, that Matteo, because if we don't know which machine you are using, the protocol can be the same for the different type of energies. My question is what you were using and why.
And so the specific machine, maybe Dr. Donat can help us because he has the complete idea, but actually is an electromagnetic one with one manipulus, So we use that type of the focus shock wave.
This is a machine by Dr. Di Giorno, piezoelectric technology.
Piezoelectric, yeah, with one glass or multiple glass. It's very important because, if you use an electrohydraulic, for example, you can use less time of left frequency of treatments and the response that we know, we that have experience in this. I have used all type of machine. That's why I'm telling this. Is the recovery period is shorter if you use electrohydraulic, and it's shorter with if you use electromagnetic. It's shorter in electrohydraulic most of all the machines, and the energy use is completely different. That's why you have to say which machine you are using to that protocol. It's very important for the papers if you want to publish. That's why my comment.
Okay, thank you so much.
Yeah, that was a very important point, Leonardo. No doubts about that. We will go ahead with the last presentation that is about non-unions. We will have Dr. Salvatore Tecce from Tor Vergata University in Rome that will talk about this interesting indication of shockwaves.
Hello, everyone. Maybe it's better if I kept the camera off because I have a very slow connection here in the hospital in my office, and I'm afraid that the computer will turn off sharing the screen and the video together. It's a great pleasure to be involved in this webinar, which regards focal shock waves in musculoskeletal pathology, non-union, and pseudoarthrosis, a very important and controversial topic at the moment. I want to especially thank Alfonso Di Giorno and Dr. Moya for the invitation, and Professor Tarantino, my mentor. Okay. As is well known, consolidation delays, pseudoarthrosis, stress fracture, and aseptic necrosis are standard indication for shockwave therapy. Our team in Tor Vergata especially focuses on the study and efficacy of shock waves in the treatment of this pathology. Here on the right, we have the standard shockwave indication according to the Italian Shockwave Society. And today we are here to present our experience. We collected data between 2021 and 2023 at the Giorno Center. The patients enrolled were predominantly men aged 40, no smoker. Only a small number of patients were affected by septic pseudoarthrosis, but these are probably patients suffering from low-grade infection, and we didn't know when we started the protocol. Each patient underwent an average of 8 sessions, and we first of all evaluated the trend of the VAS as the cycle progressed, and we found an improvement in pain symptom in over 19 of the patients. And as we can see, this is the trend. This is the VAS trend from the first session to the first year of treatment. Alongside the VAS, the radiological progression of the treatment was evaluated for each patient according to the non-union scoring system, which is here represented. And here, these are the results about the non-union scoring system with a clear improvement of the radiological profile after 1 year of treatment. And here we have our two of the most significant clinical case of our experience. Here we have a 63-year-old woman with a humeral shaft fracture treated with an intramedullary nail. A fracture after a fall on the beach. We are talking about a non-smoking sedentary patient. The patients came to our attention after a diagnosis of union delay and underwent a cycle of 10 shockwave sessions. The first is the X-ray with which the patient presented after the first section, and we have the X-ray during the treatment. And here we can see we have the net improvement of the symptoms 6 months after the end of the treatment, starting from 8 at the first session and 1 after 6 months. Here we have also the radiological control 4 months after the end of the cycle with shock waves, which a well-represented bone callus. And this is our second case report. We have a very young patient, 33 years old, suffering from a fracture of the right tibia following a motorcycle crash. The patient underwent 12 shockwave sessions at the Giorno Center in Rome. And as it's possible to see from the radiograph, we can appreciate a complete radiological resolution of the fracture and also a complete resolution of the pain symptoms. Okay, thank you so much for your attention.
Thank you very much. Very interesting. Uh, you told us that you apply 8 sessions of shockwaves. That's the standard number
No,
of.
that's not not the standard, because we have
Oh, okay.
different patients. That was the average of 8 sessions before the patient stopped following us at the Giorno centers.
Good. And when do you take your first X-rays? Because there are some different points of view related to the pre the protocol, the post-treatment protocol. When you usually get your first X-rays after the treatment?
Yes, this is quite difficult because these are patients treated at the Di Giorno center, but the diagnosis was made in another center. So we ask to the patient to do an X-ray after the first session, but the results are quite controversial just because at the Giorno Center, we receive the patient. We don't do the diagnosis of non-union. So it's difficult to compare the patient according to the first X-ray when they start the treatment.
And after the treatment, you follow up the patients, or the patients go back to their surgeon and they
Now we
follow?
follow up the patient. We usually phone them just to check if all it's right, and they ask them if they can do an X-ray and send us by email, just to check the bone progression, the bone callus.
Good. Yes, perfect. Yes, in our case, I don't know, Leonardo, in our case, it's more personal. The follow-up, generally, we have the chance to have a protocol. We get the first X-ray 6 weeks after completing the first 3 sessions, and then we get another X-ray at 12 weeks. We feel that we must get a clear idea of the progression about 12 weeks, but we know that the quality of bone could improve till 1 year. So sometimes we need to go ahead with more sessions, but generally we begin, in my case, with 3 sessions, and then if necessary, if at 12 week we do not have a complete healing, we use more sessions. But I think that it's a very good indication that it is clear you can show the X-ray before and after shock waves. So there's no discussion. That I think that the control group is the patient itself, because it is clear that that patient is referred for shock waves because there are no changes, there is no improving with the regular treatment. And it's a patient that has the indication of surgery, but we have the option to treat them with shock waves. Do you have experience with patients under 18 years old, Salvatore?
No, no experience at all. No experience at all with so young patient, and that's a limitation, I guess. That's a limitation.
Well, in fact, I have 2 personal cases that I treated. One was a 12 years old guy that had an osteomyelitis, an acute osteomyelitis when he was 8 years old. His femur practically disappeared, and he was treated in the Garaham Hospital. Is the children hospital, the biggest children hospital in Argentina, and they did a great work. They with a masquelette procedure, have the chance to recover most of the femur, but there was an area with no consolidation. So the idea was to perform a new surgery after 4 years of having several surgeries. But we were lucky that with 3 sessions, the bone healed in 1 month. Generally, children have a very quick recovery. And I had a case 2 weeks ago. I got the 12 weeks X-rays, forearm fracture that was operated because was displaced fracture of the ulnar and the cubitus, and the cubitus didn't heal. They had a endomedular rod, and the idea was after 9 months of follow-up after surgery to go ahead with a new procedure, operating procedure. And we were also lucky that with 3 sessions of shockwaves, the non-union completely healed. So I think if we have a very specific cases, I'm talking about 2 cases in 20 years, but in very specific cases, it could be an option even for patients under 18 years old. I think, Leonardo, that you also have some experience about that.
I have had some cases in not so young people, but I have had, and I think I have the same idea as you. In some specific cases, you have to have the indication. But I want to tell other thing. How long we must wait to say that the shockwave has failed after a treatment? And we have seen that we have to wait taking X-rays time by time, every month or every 2 months, until 1 year. I have an experience that marked my my practice with one young girl that we have done to her after a failed surgery with the good stabilization with the plate. We have followed her for 1 year taking X-rays, and she didn't have any callus formation in every control that we did. So we decided 1 year after to operate her, and what we saw there was that the plate was producing a chemotoxic problem in the bone, a reaction in the bone, that it was impossible with any biological stimulation to solve this. So we have to clean the bone and put a graft and a new plate with best quality. So the thing is that we have to have some protocols to follow these patients. The first X-ray 2 months, then you have to follow monthly, and not pass if it pass a year that there's not consolidation, we have to have another conduct. That is my experience. And in young people that I have had a couple of cases, I agree with you.
We had the same experience about the time of waiting until we can see the result on the X-ray using focal shockwave therapy. But what I want to say is that currently there are more than 20 peer-reviewed publications available reporting about the use of shockwave therapy in bone healing, disturbance, and all of these publications comparably show significant healing rate of the fracture non-union. So most of these articles probably are just retrospective core studies with low evidence, but this might be owed to the fact that the development of non-union has an extreme high number of different regions, such as, I don't know, location of the fracture, initial soft tissue damage, time to first aid and surgery, quality of surgery, concomitant injuries, complications. So due to this fact, it's quite difficult, maybe it's impossible to create two comparable cohorts of patients suffering from non-unions in approximately the same anatomical region with similar previous surgical procedure to evaluate different treatment option for study purposes. Maybe surgery in Italy, in our experience, is still considered the gold standard for the treatment of fracture non-union. Usually, the previous implant is just removed, followed by decortication of the fracture. I don't know if it's your same experience. Decortication of the fracture and removal of the interposed soft tissue. However, in our experience, especially with Professor Tarantino, a very critical point of this surgery, which need long experience, is to judge precisely the vitality of the bone fragment in the vicinity of the fracture. While on the other side, the procedure of the shockwave therapy is easy to perform and has a short learning curve, and there are just minor side effects which can include reddening, swelling, and occasional petechial bleeding, hematomas, without any clinical impact. So no major side effect reported. We can consider maybe shockwave therapy as the therapy of first choice for non-union, in your opinion, or maybe it's better just still considering surgery as the gold standard? In my opinion, maybe the first therapy of choice in some patients is just focal shockwave therapies. And even in my experience, I don't know if you agree with my point of view.
Yes, Salvatore, I completely agree, specifically when the basic conditions to apply shockwaves are present in a specific case. But I think, as you said, that it is worth to try it, uh, that we are surgeons and we use shockwaves as another tool, or most of us are surgeons, and we use shockwaves as another option, another tool, and we if we do so, if we, because in our experience we consider that it is a good idea. As you said, it is not easy to have two homogeneous group to compare with the same treatment. There are just a few papers. I am thinking about the paper by Furia, another paper by Notar Nicola on scaphoid, but they are not papers. They are not papers either about surgery of high level of energy, of a high level of not energy, high level of evidence.
Evidence.
So if you go to Cochrane, and you check, for instance, the surgery of non-unions of clavicle, you will see that they have no indication, because they have not a surgery that they could recommend based on evidence. The difference is that we are not epidemiologists, that we are doctors, and we have a patient in front of us asking for a treatment or a result, and we cannot say I am paralyzed because there is no evidence. We need, according to our experience and common sense and medical standards, to offer them an option. And in my hands, if I see that it is a chance to get a good result with shockwaves, that would be my first indication. But explaining to the patient that there is no method that I could give 100% of accuracy for the result.
Totally agree. Totally agree with you. We have the same experience. And maybe about its use in children, we are not a pediatric hospital in Tor Vergata, but perhaps it would be interesting, starting from this webinar, to create case report using the knowledge of this new company.
Salvatore, I will send you there is one of the patients, the one that was treated on the femur that was published. I will send you the publication to you, and I am happy that I was working with the team of the orthopedic department of that hospital. That is one of the hospitals with most reputation on children care in Latin America. And I will also send you the other case. And your words are giving me the chance to give a final idea of what we are trying to do here. I think that to begin, I want to um, thank Dr. Di Giorno, because in fact he was the one who began with all of this. He gave us the chance to get together, and he gave us the chance to work together. And after his first step, things were really going on in a very fluid way, because we all have passion for this topic. I think that Salvatore, both Mateos, Alessandro, seeing that there is young and smart people getting involved in this topic, give us the hope that this method will keep on developing, uh, besides any bias, just science, as we like to say. And I think that in the future, in the next future, we will have the chance to work together, to have projects together, and you can count on us. Perhaps Leonardo and Alfonso. I am not trying to look younger, but both of them are the ones with the greater experience in this session, and I think we must continue with their experience and have their support to keep on getting deeper in this amazing universe of mechanobiology and mechanotherapy. Leonardo, I don't know if you want to say something.
Yes, thank you very much for all the Italian young people to be here. I think that we have to modernize what we are thinking of this new type of therapies that are a company of the surgery. Is not an antagonic thing of the surgery. We can do both things with any problem. But the way to do this is to separate with a very good level of evidence which therapy is for which pathology, and when we apply one and when we apply another. And our obligation now, from now on, is to improve the type of papers that we publish. We have to have a, a, a completely good evidence when we are saying something, not having any bias when we are saying we're doing our papers. And also we have to have meta-analysis of both, of any type of treatment, to tell us if we are doing well or we are doing bad things with these new treatments. So my opinion, as and unfortunately one of the oldest guys here, is that we have to improve the way to do medicine. Medicine for us is not only a practice, is a practice, but we have to have papers that make us do this practice with completely faithful that we are going to have a good result, and good criteria to apply the treatments. So I think that this first meeting is very important, and I hope to have meetings with all parts of the world, that we could have a common way to see medicine. Thank you, Dr. Di Giorno. Thank you, Dr. Moya, to be the one that are organizing this. And thank you all the young people that we hope to have them, all of them, together doing good medicine in the future.
Alfonso,
very much.
oh, go ahead, Alessandro, go ahead.
No, I'm agree. For example, what a question to Leonardo. With Professor Procini, we treat only elbow and shoulder. And I wonder, for example, why for the medial and lateral epicondylitis is no agreement for two similar conditions. We systematically treat with overlapping results. And I wonder if you, in your experience, you made the same indication, the same protocols, or is it just a problem of insufficient data, the no agreement in the literature, in the evidence-based medicine?
Excuse me, Daniel. I think that this is a very difficult pathology, and the use of different type of energies with different type of machines and with different, but that reason with different protocols can do the treatment something used in the same way for different authors. The also problem is that we have two types of energies, that is pressure shock waves and focal shock waves. And the papers are not done in the same way because they're different instruments. So we have to make some way to know which machine we are using in which type of pathology. And the other thing is to think about the aphorism of Dr. Salter: do good decisions for the treatment and not bad incisions. So if you know with which instrument you're treating, you are completely sure that the pathology is well diagnosed, you will have more facility to do best papers and common ways to treat. But making the difference that is impossible to unknown the different type of machines. That is my way of thinking of your question.
Thank you.
Okay, perfect. Alfonso, you want to say something to finish? Turn on your microphone. You can parla italiano, che ti capiamo. Turn on your microphone, please.
Allora, I am really happy with the work we are carrying with this for Italian orthopedic school, and above because I can transfer my experience to futuro operator of this regenerative medical method, and above that futuro orthopedic specialist can have a scientific approach on this treatment, cosa che è mancata fino adesso, perché gli ortopedici lo prescrivono per sentito dire, vanno a fare, e questo è un po' la cosa negativa delle onte d'urto. Poi dico, ha fatto le onte d'urto, non sono servite a niente.
Bien. Grazie,
questo potrà servire per un approccio diverso, più scientifico anche della classe medica, dei futuri ortopedici, oltre che dei futuri operatori. Delle volte vedo ancora degli operatori che non le fanno loro, che attaccano le macchine, c'è di tutto. E poi i risultati cadono.
Grazie Alfonso.
I futuri operatori, che sono veramente molto bravi, Donà, Cantore e tutti gli altri, possono essere diversi. Grazie.
Grazie a tutti. Grazie a tutti. Buonanotte.
Grazie a tutti.
Grazie a voi, grazie a voi. Ciao a tutti.
Ciao.
Buonanotte. Buona serata.
Grazie a tutti.
Ciao.
Grazie.